Hi, Alice. It's Farah.
Hello, Farah. How are you doing?
I'm doing great, and I'm really looking forward to hearing you talk. I know you're going to do an amazing job, my sister.
Thank you so much.
You look really nice today. Are you wearing a Ugandan dress?
Not really.
Okay.
One of the ordinary dresses.
I can't wait to meet you in person next month.
Sure, same here.
Hello, everyone. We'll wait for one more minute and then we will get started. Okay. We'll get started. Jessica, if you want to start recording. Hi, everyone. My name is Anna Langer, and I'm a professor of the practice in the Global Health and Population Department. And I also lead a program called the Women and Health Initiative. Both the program, my program, and the department are proud co-sponsors with the Harvard Global Health Institute of the LEAD Fellowship. And we will hear from one of our 2021 fellows today, Alice Kayongo. Alice is a public health practitioner and a human rights advocate. She's currently working as senior policy advisor with WASI Health, based in Uganda, a regional advocacy group championing health for all in Africa. She leads efforts to amplify the voice of communities in decision-making processes that affect their health and lives. Her work triggers ownership and increases communities' meaningful participation. Alice is also an active researcher within the health, women's, and children's rights development sector in Uganda, Africa, and internationally. Her research interests for the health development sector are in health financing, the impetus for community mobilization, sorry, and engagement in monitoring and evaluation of health service delivery at community level. Alice holds a bachelor's degree in sociology as well as a master's in public health. Alice, welcome. The floor is yours.
Thank you so much, Anna. And please allow me to share my screen now. Can you see my screen?
Yes, we can. The only thing
Thanks.
is that we also see the slides on the left, so you may want to use presenters mode.
I'm actually using presentation mode.
Presenters view, I think it's called. Perfect, now it's perfect.
Great. All right, so thank you so much, Anna, and good morning, good afternoon, and good evening to colleagues online. As mentioned, my name is Alice Kayongo, and I'm here this evening. It's evening in Kampala, Uganda, where I am based, to present to you this brown bag seminar on the centrality of women's leadership in global health. And to bring out the key issues of the centrality of women's leadership in global health, I'll be sharing some reflections from Uganda's COVID-19 response. For an outline, my approach will be that I will refer to women's leadership, but I will mainly focus on first the global health context, what it is like. I'll then get on to talk about why we are focusing on women.
Alice, we lost you.
And I will continue to share what response to that. Can you hear me?
Now we can.
Can
We
you hear
lost
me?
you for a few seconds. Now we can. Yes.
All right, sorry about that. So I'll proceed to talk about Uganda's experience with regard to the COVID-19 response, and I will end with providing some lessons for global health. I want to start off with the global health context, and specifically what I mean by global health delivery.
Go ahead, go ahead.
I can hear you. Can you hear me?
Yes, we
right.
can now. Yep.
Yes, so I would like to start off with the global health context. And what I mean by global health is basically talking about the entire spectrum of service delivery, right from the domestic level to the global level. I will not focus on what is usually referred to as international health, but this time I am focusing on global health, mainly looking at all the spectrum of services that will be provided or are provided from domestic level to international level. And for me to be able to explain the global health context, I will start off with mainly two indicators. I will first of all mention indicators to do with HIV, the HIV response and where we are now globally. So as you may see the statistics before you, globally, as of 2020, we had a total of 37.7 million people living with HIV. And of these, 19.3 million were women, 1.7 million were children. And this clearly indicates the fact that women are much more affected by HIV. It affirms the fact that we have seen, and we know that women are disproportionately affected by HIV. When we get to new HIV infections, we realize that in 2020 alone, the world had 1.5 million new infections. And I will get into this in the next slide, just so we see what the statistics have been like for us with regard to new HIV infections. First of all, on a daily basis, we have over 4,000 new infections occurring amongst adults and young people. And 90% of these are actually occurring amongst those 15 years and above. But 51% new infections are happening amongst women, and 21% of these are actually happening amongst young women aged 15 to 25 years. There's a 13% married or partner women experience of intimate partner violence amongst women. And this has also been further emphasized by the fact that women who have experienced intimate partner violence are 1.5 times more likely to acquire HIV. So this figure, or these figures, clearly indicate to us the measure of the impact HIV has had on the world, but more so on women. And to further talk about this, or to further emphasize this issue, I pull out the example of new HIV infections in Sub-Saharan Africa. When you look at the figure on your right, you realize that women are actually much more affected. Women in Sub-Saharan Africa are actually much more affected. We have over 61% new HIV infections in Sub-Saharan Africa happening amongst women. 25% of those are happening amongst young women aged 15 to 24, whereas 27% are happening amongst women 25 to 49 years of age. So this again further shows us the fact that women are being disproportionately affected by HIV. And just, before I leave the global context, it would be unfair for me to mention anything else but COVID. And for this reason, I want to switch from the HIV response and go to COVID, mentioning that globally, we have had over 494 million cases of COVID. And if you see the figure that we have on the right, this is a figure of cumulative COVID cases globally, disaggregated by sex. You realize that women and men are almost, infected with COVID about the same. The difference between the two is not exactly statistically significant. However, we realize that for the 494 million cases globally, over 70% of the health and social care workers who are caring for over 494 million people are women. Now, this shows that women are actually at the forefront. Women are at the center of caring for people with people who are infected with COVID, but also those who have been affected in one way or another. And 90% of nurses globally are actually women. These statistics are just further showing us the fact that women are key and women are central in the healthcare spectrum. A recent study indicated to us that during COVID, over 45% of women reported to have experienced gender-based violence. Either they experienced it themselves or they have had a fellow woman experiencing gender-based violence. And this is actually, there's a high likelihood that gender-based violence will lead to HIV acquisition, which means that COVID would likely lead to gender-based violence and later on lead to a likelihood of HIV acquisition. So moving on, I would like to go on to my next component, as mentioned in my first slide on the approach that I am taking. Why am I focusing on women for this presentation, or why do we need to focus on women being at the center of global health? So first and foremost, I categorize this in 3 areas. And the first area is on the high burden of care. If you see the image on your right, this is an image of a woman that it's one of those images that has been going around. I think this was one of the images that many of us shared on International Women's Day, showing the burden of care that women have. They care for the sick, they care for their families, they care for their children. They basically care for everyone within their families and beyond their families. There's a study that has indicated that women have actually have had a double shift as a result of COVID, meaning that they do have work, formal jobs, but they also have work 24 hours a day when they get back to their homes. This, I must say that myself, I have actually experienced, because during the lockdown, when we were all working from home, I was both a full-time staff at Work Health, where I am employed, but I was also a full-time parent. I was a full-time mother. I was a full-time wife. And it was so hard to balance all these things, all these responsibilities at a go. And studies have also indicated that 31% of women versus 13% of men with full-time jobs have more work to do than they can possibly handle. And they spend 2.7 times of unpaid work caring for household members, but they do not only stop at caring for household members, they also spend 1.3 times as many hours caring for non-household members. So women are not only responsible for caring for those in their neighborhood, in their immediate neighborhood, but they also care for those in basically their community within their homes, but also beyond their homes. And this further shows us that the extent of the burden of care that women do have or women do experience. My second category as to why I am actually focusing on women is the fact that women play a central role in the delivery and support of healthcare. And if you see on the right, I have a beautiful image that depicts a story which I would like to share with you all. This image is of a market in Kampala, in Uganda, actually. This is a market along one of the highways in Kampala, market that was constructed very modern, very formal, very beautiful, constructed to be able to ensure that market vendors can actually utilize this market for their own safety, because it's located along the highway, and many of them were actually constructing their stalls towards the road, and which could possibly cause injuries due to road accidents. But surprisingly, this is a market that, although it is modern and was well constructed, unfortunately it has not been utilized. It was constructed with 200 stalls, but up till today only 5 stalls have been occupied. And if you see right opposite the market, you will see a makeshift stalls that vendors actually choose to use rather than use the modern market that was constructed. And the reason, or the story behind this picture, is the fact that the people who are most affected by an issue, if you do not include them or bring them to a decision-making roundtable, then it is likely that you will not be able to get the objective or achieve the goal for which you strive to accomplish. And so this is one of the stories that I would like to share with you, and I would like you to hang around this story, because later on in my presentation, I'll keep referring to this story. The third element of the reason as to why I am focusing on women is the fact that women have the potential to handle their problems if they are supported to do so. We have seen in the slides before that the women are at the front line of healthcare, and that they are central to healthcare. They are important, but unfortunately, they are often devalued. They are unrecognized, and they're basically an unrecognized part of our economy. And when you look at the graph that I have towards the end of this slide, it's a graph that was adopted from one of the studies that depicts how women actually move through positions. Women start off very well in care, or when they're employed, they start off very well in high numbers. But the higher you go, to senior positions, you realize that the numbers decrease, the men start to take over. But remember that we have said that for us to be able to accomplish the goals that we have set, we need to involve those that are most affected in key decision-making processes. And this figure alone indicates to us that we have fewer women being fewer women employed or taking up positions, leadership positions, and that definitely has an impact on policy issues. It has an impact on decision-making issues, and it has an impact on allocation of resources, and much more, just to mention a few. So now, having mentioned all that I have mentioned, I would like to move on to Uganda's experience in the COVID-19 response. As mentioned, the centrality, I would like to use Uganda's experience as one of the stories that I would like to share with you all. And before I can even get into the key critical health areas or key critical issues around the COVID response, I just want to mention to you that because of the affirmative action in Uganda, we have seen women rise to key decision-making processes. We have seen several women in Uganda being considered for key leadership positions. So the statistics here actually show you the number of women that we have in politics and in key decision-making processes. And I know that many of us know the role that politics plays in health service delivery, in allocation, and so much more around health. So the fact that we have these numbers of women in key decision-making processes is good enough for us to see that Uganda's health response, or Uganda's health sector, is on the right track. And to emphasize this, I share with you a few images of key decision makers that we have in Uganda, all of them women. we are such a generous country, I must say, except for our president who has been in power for over 37 years. At least we can see that we have a couple of women rising, every other term to key decision-making processes and key political seats. We have a vice president who is female. Our prime minister is female. The first deputy premier is female. We have a speaker who is female. And we also have a first lady who is also a minister of education. We are that generous that we do not only leave first ladies to be first ladies, but we also give them, extra assignments as ministers. So our first lady is also minister for education. And we know how education is really central, how it is key for the health sector, especially with regard to awareness building. We also have a minister for health who is female, permanent secretary. The permanent secretary for Ministry of Health is the topmost technical person at the Ministry of Health. She is female. And lastly, as an example, is that we have a minister for science, technology, and innovation who is also female. She was just promoted recently, but during the peak of the COVID pandemic, she was senior presidential advisor on epidemiology. So she played a key role in advising the president on key areas or on the COVID response in the country. And moving on to the statistics of Uganda, the reason that I think Uganda has been or is one of those, success stories that we can share is that although Uganda has been affected by COVID, just like any other country in the world, the statistics are not as scary as we have seen in other places. And maybe, there are reasons to explain this. Some of those I will explain as we move on, but just to mention that these are the key statistics that we have. To date, we have seen a total of 163,936 total cases of COVID in the country. As of today, we have also seen that we have over 17 million vaccines that have been administered. And these 17 million include individuals who have gotten 1 dose of a vaccine, individuals who have gotten 2 doses, individuals who have gotten a booster dose, 1 or 2. So in total, we have seen over 17 million doses of COVID administered in Uganda. So switching to the key issues around the COVID response, as mentioned to you, the head of the Ministry of Health, as well as the permanent secretary, or the 2 senior most political and technical officials of the Ministry of Health are female. Now we have these at the policy level. So we know that at policy level, to an extent, we can, we can be in comfortable seats knowing that some of the issues that are affecting women and their health as well as their well-being are going to be addressed, are going to be listened to by the fact that we have women leaders in topmost seats. At the same time, Uganda has a history and experience in fighting epidemics and all related stigma. We have fought Ebola, we have fought cholera, we have fought Marburg. And if you realize, for those of you who have been following, some of these trends and stories, Uganda is one of the countries that hasn't been heavily affected by these epidemics, despite the fact that we do suffer from them, just like our neighbors in, the Democratic Republic of Congo, countries in West Africa. However, we have not experienced them to the measure that other countries have experienced these epidemics. And lastly, is that we have an infrastructure that is easily activated in times of epidemics and pandemics. So it was a soft landing for us in, with the advent of COVID, for us to be able to use the infrastructure that has already been put in place to respond to epidemics that we have experienced in the past. But more so, I need to mention that we have also focused on local science and traditional remedies. If you see to my right, We do have a local remedy that we refer to as Covidex. It is one of those that has been approved by the National Drug Authority as a supportive COVID treatment in Uganda. And it is one that several people swear to. I must admit that I have used it myself, and I should say that I did have a positive impact from this remedy. I'm not the only one who has used it. In fact, there were long queues when this product was approved by the National Drug Authority, as many people were able to use it, and many swear to it as one of those remedies that has actually helped them sail through easily with and if they have a COVID infection. I need to mention that during the lockdown,
nobody will retract that. Yeah.
So I will proceed, and I need to mention that during the lockdown, there was less movement. Health workers were not moving from facilities to communities. Communities were not moving, individuals were not moving from communities to facilities, but we saw a rise in the role of community health workers as frontline health caregivers. Many of them are women, and they do this work for almost peanuts if they get any compensation. Otherwise, majority of the women doing community healthcare work do it out of love, out of passion, getting almost no compensation or no remuneration per se. And here I have, a story of a colleague of mine, a friend who is seated. She is disabled, but she's a community health worker. Even during COVID, my friend Maxensia was able to leave the comfort of her house, move from house to house, offering home-based care to people who are not only infected with COVID, but also friends who were, heavily impacted by the effects of the lockdown, including people living with HIV. And despite the fact that community health workers were actually, free to move out, to one extent, they were freer to move out compared to the bigger part of the communities, they were also, to one extent, depressed in the fact that they were not freely doing the work that they love to do to the extent that they had wanted to do it. However, they did devise means of getting together to, discuss, to share, to learn, to be able to share and compare experiences as a means of helping them to hang in there, to move on, and to be able to support individuals and friends within their communities. Women, again, have been extremely compliant to COVID protocols and the spread of infections. I share the images here with you as images that portray significant compliance to COVID protocols by women. These are images that were taken in the markets of Kampala, where the vendors, majority of the vendors, are women, but they were not allowed to leave their workplace to go back home because the country was trying to contain the spread of the pandemic. So many of the women complied very well. They slept, they spent nights and days in the markets, as you can see on my left, with mosquito nets hanging, at any point in the market over the stalls, just to protect them from mosquito bites. But you also see on my right that they have improvised with boxes to be able to make mattresses to be comfortable as they sleep. So just this compliance alone is one of the examples that show how women have actually come out and tried to contain or to participate or to make a contribution in the COVID response in the country. Despite the fact that we have had the successes that I have shared as a country, we have also seen these successes coming at a cost. First of all, Uganda has a total of 354,000 teenage pregnancies. These were registered in the year 2020 alone. However, as of June 2021, an additional 196,000 new pregnancies were reported. were registered in the country. And this was mainly attributed to the fact that our lockdown saw schools being closed for over 2 years. Uganda was the only country in the world that had schools closed for over 2 years. When you see bottom left, you find that this is only a district. This is a newspaper cutting. Only one district registered 2,300 young girls conceiving during the lockdown period. We saw a rise in gender-based violence, and this was extremely high to the extent that we saw the US ambassador in Uganda visiting one of the gender-based violence shelters to be able to visit people who have been affected or people who have suffered gender-based violence as a way of encouraging them and providing to them. So these are some of the issues that we have, the cost that we have had to pay as a result of the COVID pandemic in the country. Having said all that I have said, I want to say that all these lessons and the experiences that I have shared, I have 3 takeaway lessons for us for global health. And first is that we need to revisit and to decolonize the idea of global health as illustrated in the image on my right that I did share with you before. We need to know that the care work that women do in health is central. For as long as we do not revisit, as long as we do not decolonize the idea of global health and recognize the fact that care work that women do is central, we may not be able to accomplish the goals, for example, the Sustainable Development Goals, especially those that are focusing on health. But second, we must be able to acknowledge that women in the front lines constitute the largest frontier for health, for the health response. We must therefore recognize, we must value, and we must strengthen this role through financing the care element of global health. We have seen, I have mentioned an example of community health workers. Who knows how much more they would be able to do if they were recognized and compensated effectively, but also meaningfully. I have seen our neighbor country in Kenya, they recently passed a legislation that is going to recognize, that is going to ensure compensation, meaningful compensation, and provide motivation for community healthcare workers. How I wish that this is one of the interventions that many of other countries in the world, mine inclusive Uganda, I wish that this is one of those interventions that we can be able to learn and to replicate in many of our countries. And I want to end with my last recommendation, which is the third and last, noting that we must identify and eliminate the obstacles that are preventing women from advancing to the top levels of leadership. And some of these obstacles are institutionalized patriarchy, they are traditional beliefs, they are pay disparities and inequalities, and so much more. Basically, women's leadership can no longer be an exception women's leadership can no longer be an exception. And in the case of Uganda, as in the case of Uganda and in a few other countries, I bring back this image to remind us all that women start off, at entry level, we have many women, but as we go on along the pipeline to leadership position, we realize that we have actually fewer women. But for us to be able to identify and eliminate obstacles, we should be able to see to it that women are actually rising, increasing to top positions, policymaking level and political level, to be able to provide and allocate meaningful resources to the key areas that actually have a great impact on women's health. I stop here. I thank you so much, and over to you, Anna.
Thank you so much, Alice, for a wonderful presentation, a very thought-provoking one. Now we have some time for comments, questions, and answers. Whoever wants to make a comment, please raise your hand, either electronic or physical hand, and we can also monitor the chat. When people think about their questions or comments, I can start with one. Alice, what you described is such a perfect case study for the Women in Health approach and the Women in Health initiative that involves looking at the health of women throughout the life cycle, but also the contributions that women make as healthcare providers, either in the formal healthcare workforce or informally, as you said, at home and in the community. Some years ago, we published a lengthy report in the Lancet about that, and we grouped the recommendations into 4 categories that really resonate well with yours. So I would like to mention them and then ask you if you have any comments. We grouped our recommendations into value women, count women, compensate women, and be accountable to women. Well, I think that you went over most of them, if not all of them, but I wonder if you have any further details to provide or reaction to what I told you. In any case, I would love you to read the report and send me any comments you may have.
Thank you. Thank you so much, Anna. And indeed, I cannot agree with you enough. As mentioned, during my presentation, if we want to, if we are really involving women, then we must be able to recognize and value women. We must be able to compensate them just pretty much at the same way we do, compensation for any other, for men, for example, in healthcare. We should be able to be accountable to women. So basically, Anna, I want to agree with you entirely with the 4 categories that you were able to highlight during the report, and to mention that these are the areas that we keep grappling with almost all over. And I am so glad that a country like Kenya has come up with an initiative that is actually ensuring that women, women, especially community health workers, are recognized, they are valued, they are compensated, and they are given a motivation, because, for example, they are all entitled to a national health insurance. As we speak, this is a legislation that was passed, I think, 1 or 2 weeks ago, and I think it will go a long way in motivating and morale boosting community health workers who have done this work at almost no cost for so long. So I can only imagine what impact or what effect we are going to have as we move along, especially now that we see them being recognized, valued, and compensated. Thank you.
Thank you. Thank you very much. We need to follow up the Kenya experience, which seems to be so inspiring. Kevin, you have your hand up. Please feel free to ask your question.
Thank you, Anna. Thanks so much, Alice. This was really a fascinating and very wide-ranging presentation about really fascinating topics. I wanted to ask you a little bit more about one of the slides that you posted, which showed a really impressive kind of range of women having high leadership positions in Uganda, kind of across the political spectrum, but really concentrated, as you noted, in the Ministry of Health, also in other ministries which are really critical for health, like education, where you noted the First Lady is the minister, and you were really highlighting how having women in these positions can really, excuse me, change decision making, and that their voices can be represented. And then you mentioned Uganda had many successes with COVID, but also this really unusually long closure of schools, and there are a lot of costs associated with that. So do you have any insights or any thoughts about how having these women in the senior leadership roles in those ministries, how that played into decision making around COVID? Were they more sensitive to these challenges, or were they still making choices that, as you mentioned, increased care burdens, had a lot of other challenges, but maybe these were the trade-offs that they faced? Did their representation lead to different decisions?
Thank you so much, Kevin. And so what you mentioned is actually true, for the fact that despite the fact that we have several women in leadership, key leadership positions at ministerial level, we did have this long period of school closure for 2 years, which also saw a high number of teenage pregnancies. And so one would wonder that really, you know, if we have, you know, this number of women in leadership positions, how come we do have such effects on, learners in Uganda? And I must admit that, to a great extent, we know that, yes, we have women in, key leadership positions, but then at times the element of patriarchy does, come in at times. And so there's a lot of decision making that is actually based on, I should say, topmost positions in the country, high positions in the country, many of which are positions that are taken up by men. And, as you can imagine, Kevin, patriarchy is one of those issues that is so hard to, get away with, despite the fact that we have women in, leadership positions. At times, patriarchy does take over. However, these are areas that we do recognize as some of the gaps that, despite the fact that we have more women in leadership, we do have some gaps that have been highlighted, where we feel that the performance of women is not to the extent or to the level that we expect it to be. And many of them do admit the fact that while they highlight some of these challenges, they can only do what they can given the circumstances. And so some of the obstacles that I have been talking about, including patriarchy, are those obstacles that we should be fighting. Just even having discussions or conversations around patriarchy and how to reduce or even totally eliminate it is good enough. But if we can continue finding interventions that can help us reduce this and see to it that the decisions that women are making are actually decisions that we do respect, we do take on, we accept and embrace, then I think that will take us to higher levels. Yeah.
Thank you, Alice. Any other questions or comments for Alice? Oh.
I can ask a question.
Oh, yes, Dorit, go ahead.
Hi, thanks for the presentation. Could you just elaborate a bit on the role that community health workers played in the COVID response specifically? Like in the beginning, were they subject to the same sort of stringent transportation restrictions, and was that loosened? Were they given any sort of specific directives from any levels of government in terms of what to do to continue service delivery?
Oh, yes. So we had community health workers. So first of all, during the lockdown, there was restricted movement. And the only people that were seen on roads moving were health workers, mostly, I should say, health workers who are employed formally, those with IDs, those who can be able to actually confirm that they're health workers. So when you see community health workers, unfortunately, it was very hard for one to prove that they are community health workers, because remember, not many of them are actually recognized. They are not given any forms of IDs to show that they are community health workers. However, during the COVID lockdown, the community was encouraged to identify key individuals that could be referred to as community health workers. And these are the individuals that were helping, for example, transport medication from facilities to the communities. We have people, people with chronic infections, people with chronic diseases, with diabetes, with HIV, with cancer. We had pregnant women who were bound at home, and some of them were unable to go to facilities. So at this point, the community health workers would come in, be able to transport medication from facilities to the communities, and vice versa. They would also be charged with the responsibility of picking samples from the communities and taking them to facilities to for tests and any other investigations. So this is a role that we saw rising. At least it's one of those times, few moments, where you could see that community health workers are actually being recognized as community health workers, because first of all, they were identified by their own communities, and the communities would communicate with their local leadership, letting them know that person X, Y, and Z are our community members. So that, the community members, the community health workers were free. They were free to move, while other people were bound within their households or homesteads. The community health workers were able to move from facility to community, and from community to facility, offering services to key individuals. So those are some of the areas where we were able to see community health workers play a significant role at community level.
Thank you. Thank you very much. Any other questions? Cynthia, sorry, I didn't see your hand up. Go ahead, please, Cynthia.
No, thank you so much for your presentation. Mine is just a commentary. I hope I'm coming out very clearly. But, to just concur with your presentation and everything that you said, for me, I think what continues to linger in my mind are, how do you address these challenges that women face, especially in leadership? I think it's really worth noting that there's so many barriers that, just affect even the performance of these women. Structural barriers, institutional mindset, and even individual mindset, and the lifestyles in terms of the choices. I tend to wonder, I've observed when you talked about, even salaries, when you're negotiating for new jobs or new positions, that you end up finding out that women are actually offered the lower path, which is very sad. And at the same time, I've seen women who, just because maybe they've got other responsibilities or they're pregnant and they go for an interview, and maybe being left just because, they're in this situation of, becoming a mother, and yet maybe they're judged because of that. So I feel like there's so many gender biases, stereotypes, and issues that we do need to address to ensure that women are recognized and supported adequately to be able to effectively lead in an impactful way. So there are several issues, and I'm just happy that today we're here listening to your presentations. And even as women, we need to work together to be more supportive and make each other stronger to have the impact that we want to see in the world. So I'm just really happy that, I listened to you today, and there's so much that I've learned, what is going on in your country, in Kenya, and thank you so much for your presentation. Over.
Thank you, Cynthia. I take it well.
Thank you, Cynthia, indeed. Any other comments or questions, or Alice, any last words? Oh, Marely, please go ahead.
Hi, Alice, it's Marely. Thanks so much for a lovely presentation. As you know, I'm from Namibia, which is a little bit lower down in Africa. And I was just wondering whether you think that what you've experienced in Uganda is quite particular or specific to the African context, or whether one can also draw lines from the lessons learned in Uganda to other lower and middle income countries.
Thanks, Marely. I actually think that the lessons that I have mentioned in my presentation are lessons that can be replicated in other low and middle income countries. You will find that the lessons that I have shared are lessons that we can see in Namibia, we can see in Kenya, in Malawi, in Zambia, in Cambodia, and several other countries. It's I know to one extent we would need to be as contextual as possible, but and maybe adapt to some of the the lessons, but otherwise on the overall, I would say that they are lessons that can be replicated elsewhere.
Yes, I would agree with that. Thank you. Okay, if there aren't any further questions or comments for Alice, do you have any last words to share with your audience?
Well, my last word first is to thank you all for making the time to attend this brown bag seminar, but also to mention to you that to mention and maybe to plead that you know, for the change that we want to see, we need to involve communities or categories or populations that are most affected by the problems that we are seeing. That way, we will be able to see a positive impact on the solutions that will have positive impact on communities or on the health indicators if we involved communities or individuals or categories of populations that are most affected, because they understand the problems better, they know the solutions that will work best for them, and that way the impact will likely be to our expectation or even beyond. Thank you so much.
Thank you, Alice, for that very, very important message. So we will give you back 10 minutes of your time. Thank you all for your participation, and big thanks to Alice for a wonderful presentation. I will add, if I can find it, my hand clapping. Well, sorry, I'll clap physically. Congratulations, and thank you so much, Alice. Have a great afternoon, everyone. Bye now.
Bye.